How far way back do we go?
Yeah.
Just a bit of an overview. Do you know the beginning?
I mean, you probably know the beginning more than we do. We know it as far as when we started.
Well, the clinical associate profession started in South Africa in 2008, right, with the first class attending Sula University. And then the next class was at University of Pretoria, later that year, 2008. And then here at University of Witwatersrand, we started the class in 2009. The first graduates then began working in South Africa in 2011. Now there was quite a bit of work leading up to that. In 2005, there was a task team started with National Department of Health and with provinces, Departments of Health, and with academics and different stakeholders to create a mid-level health profession, which South Africa didn't have at the time. And then they followed the physician assistant kind of model, and they set up an undergraduate degree program here, even though in the United States it's a master level program, knowing that probably in South Africa they'd move that direction. And it had lots of support from WHO and National Department of Health to help fund the first initial cohort of students. And VOA and Victor were both the first cohort of students here at University of Witwatersrand. You guys started 2009.
Great.
So what was your experience as students first time in this program?
Okay, well for me, I didn't really know what it was about. And I just thought, okay, let me do it because it's still within healthcare and it's still within medicine. So I thought, because I want to help people, because I want to work in the hospital, I'm still sort of in the same field. And then we just started. And we're a very small class of 25.
Today we're going to do work on children's health, and we're teaching them about the integrated management of childhood illness, which is a protocol process to help treat children under 5 years old. There are 5 big mortality diseases that affect children, and this is one way we can identify that early so we can get the child the help they need before problems become too challenging, and it often becomes too late to help the children. But we're also right next to what is Soweto, which is a township that developed outside downtown Johannesburg. And so this hospital is right next to one of the largest townships where there's a great population of people. So that also makes this hospital extremely busy. And this hospital is the second largest hospital in the world. I mean, there are different facts about why, but it has the incredible number of overnight beds in the wards. The emergency department is very busy. It sees lots of trauma patients. South Africa seems to have an undercurrent of quite a bit of violence that they often say is hanging over from the apartheid days. So on any given day, there'll be gunshot wounds, there'll be stabs, a lot of domestic violence, intimate partner violence. So our students are exposed to some opportunities here of really tremendous learning and to do some emergency medicine work, also in the wards and HIV clinics, in the obstetric wards. Birth to 2 months, or are we working on 2 months to 5 years? You guys are familiar with both? You've done the recording forms of each? Yeah. Good, so whichever we see. Okay. Then we just want to introduce ourselves to the sisters. They know we're already coming. And then we want to identify ourselves to the patient and with the mother. And ask the mothers, it's fine if we interview, because we'll probably be most of the questions with mom. And then we have the opportunity, if they allow us, to examine the child. And then we can follow along with the recording form as we go. And the idea is that you guys would produce a recording form. I have here an evaluation sheet of you going through the process. Sound good? Now we hope that there'll be enough patients for everyone. We just need to find at least 3 patients. We'll see how it works. Are we ready? All right, shall we? Okay, you're holding the door.
So you mentioned this about people leaving, and then so some people don't go all the way through with it, or
Maybe 6% of the students that start don't finish the academic program, which is typical, and it's actually a small number compared to other academic programs. And then of those that practice, about 5% want to go on to further studies and maybe leave to go to another profession to study or elsewhere. About 4% are going into academics, like you guys, to come train. And then we know about 6% go into nonprofit work, and maybe another 6% are starting to go into private work. Whereas then 80% will go for the government, which is the biggest provider of healthcare in South Africa, biggest employer of healthcare.
Yeah, I mean, I think the clinical associates who leave, I mean, these are young school leaving. It's a young school leaving group, so anyone wants, what do you call it? You want to be settled, or you want, what do you call it now?
Stability.
Stability. They want stability. So they're thinking about their families and the salary. So others are quick to leave and go into other professions, or quick to jump into private because of, in South Africa, you know, you want stability and.
So what do you do here at Bertha?
Betakoa Hospital, the former Germiston Hospital. Okay, I work in internal medicine, which is an adult ward. I work in the female ward now, and also assist, but now recently also doing cesarean sections on my own. Yeah, that's what I do.
Cesareans.
Cesarean sections, yes.
And how is it going?
Good, fine. Work is good, yeah.
So where do you think you'll go from here? What's your goal?
Honestly, I'm looking to leave the field because I'm happy working. I'm happy doing my work. I'm just not happy about all the other things that are on the side. Salary, lack of appreciation. You know, there's so much. There's no growth. There's no academic growth currently. Well, close to no growth academically because there's only that one program at Wits for emergency medicine. What about the rest of us that don't want to do emergency medicine but have other specialties? So there's no growth academically. There's no growth financially. There's no recognition from our health department. So that pains me as much as I love what I'm doing, but when I go home, you know, and I want to grow. I'm not getting any younger, so.
So basically here it's a general practice. So we just see patients. It's like it actually functions more like a clinic, if I can say so. So we see patients and then we diagnose and then we treat. But if it's a major condition, then we refer. Like just right now, I just saw a patient with what do you call this, meningeocele. So it was an interesting case for me to see, and then I spoke to my supervisor, who's a GP, and then we were able to tackle the case properly, and then we had to refer the case. Okay, so this is an actual structure of the womb. There's the womb over there on the side, and then from there, then there's the placenta inside there, and then there's the fetus. So this is the spine of the fetus. The spine will connect there to the head. So the skull over there is totally gone. So because even we can't even see any other facial features of some sort. So yeah.
And what would cause that?
Pardon?
What causes that?
Actually, it's what do you call that? It's a congenital abnormality.
So how is the healthcare system structured here?
There's this big inequity of health provision in South Africa. If you have money to afford a medical aid, which is like health insurance, or if you work for an employer that can provide you that, then you can go see the private doctors and pay substantially more, but also get deductions through the medical aid scheme. But if you don't have either of those, then you can go to any government health facility and receive free care or very minimal charges for certain procedures. But there's real inequity of that distribution and what's provided, because the government health sector has very few money and resources to hire doctors, to retain doctors, to hire clinical associates, to hire nurses, to hire and staff it, and to have the resources available. You're running out of medicines. quite often.
Quite often.
Of sterile packs, quite often. You're not able to run your theaters. Whereas then this side gets all of that resources, but only 20% of the population. And so now, in the last 6 years, there's been a movement to try to equalize this with the National Health Insurance Scheme, the NHI. And so is that all South Africans will be provided with health coverage, and they can go to the private sector or the public sector. And the idea was to bring up the public sector so it meets the same provisions as the private. And so they're going to have to redistribute these resources, as you're talking about, and pull money away from private to start putting more into public. And they're going to have private doctors starting to work more in public, and public facilities accepting private facilities accepting what was public patients at that time. So there's this real move to try to mix this. It's going to be a challenge, but they're working towards it. NHI is now a nationally embraced scheme and has phases to go forward, offering kind of general 16 services of healthcare needs, from pediatrics to maternity to surgical to et cetera, et cetera. This is a private clinic set up in Soweto, and it's run by clinical associates who provide health care to the citizens of the area. Tell us more about it.
Okay, this clinic, it was opened in the 1st of March this year, 2017.
Okay.
And basically, yeah, it's just to give quality health care to the citizens, yes.
Because, I mean, otherwise people have the government healthcare system to go to, which offers basic services at a very low price, but often resources are difficult, or staff is not always there, or there's long queues, or people have to have money to get health insurance or medical aid schemes to go to the private, which often is difficult. So this fills this need in the middle. And tell us how the clinical associates work. What do they do here?
Clinical associates mainly here see patients.
Okay.
They will be taking history, assessing patients, also doing clinical exam, and then if needs be refer, we have good relationship with surrounding hospitals that always talk to them in terms of when we try to refer patients. So we have a good relationship with the surrounding hospitals that we have.
So the doctors at the hospital say, oh, I know you as a clinical associate, you're seeing a patient, Quality Health, we're glad to take this patient and continue care.
Yes.
And then I also see you have a pharmacy here?
Yes, this is the pharmacy area. Normally what happens is the patient will come through, and then when they come through, the maintainer will help them, guide them to the receptionist. After they register with it, they go straight to our vital nurses. After vital nurses, they go to the bill area. Okay. After going to the bill area, then they will go further to the clinical site. Yes.
Oh, great. And tell me, how many patients are you seeing a month?
A month, roughly, we see about 1,000 plus patients.
All right, let's go see some of the clinical associates. You're good, Apiwe. No, because remember, he can edit this.
I graduated in 2013, so I've been working since 2014 actually. Started out in a government hospital which is very different to this setting. Very, very different.
How so?
Yeah. In terms of the biggest one that stands out, workload. Biggest difference there. In government, it's a little harder because they don't really know us. They don't know what we're doing. So it's always that thing of you need to first explain what we're doing, and then there's all sorts of misunderstandings and people feeling threatened mainly. Well, that's what I experienced, threatened about our profession.
So what do you see mostly here usually?
Here at this particular, I can't say we see something in particular. It's just a lot of stuff. It's just different things. I mean, most recently we've been seeing, which is actually upsetting, we've been seeing what we call, I don't know if you know about organophosphate poisonings, children that eat rat poison, like by accident and all that stuff. Yeah, and unfortunately a few of them have died, but then that's what we've been seeing, and I don't understand why, but it's just on the rise out of nowhere. But yeah, but otherwise we see a whole host of things.
Is there something unique about CAs? You have to be passionate or curious to really do well? Or?
I would say you would have, I personally think that you have to have some kind of passion for this, because it's so new, number one, and because of it being rural based. You trying to bring a difference, trying to bring a change. So you have to have that passion that you want to change something, that you want to help people. So at least some passion in that aspect somehow. Yeah, I think you'd need that. Yeah, most definitely.
And you take all age groups. I mean, young ladies up to the elderly.
Yes, but most of our clients are between the ages of 26 and 35.
26 and 35, okay.
And we see a lot of pregnant clients as well.
I'm really impressed.
Thank you.
I mean, I educated this guy. Yeah. And now look what he's done. So if a little bit of me is rubbed off, and look, he's like, woo, blossomed into this tree, this solid tree.
Why did you guys all get into this profession when you're all PAs?
Oh, yes.
Why did you become PAs?
I give a different story all the time. So.
Why?
It's just because there's so many reasons. I think when I first said in Dr. Truscott's class that day, I think I said the story of yeah, there was we had at home, we had chickens. We had outside rooms, and there was a toilet outside. We used to sleep in there, in this outside rooms, in the staff quarters. It's those traditional old housing. There was a toilet outside, so one of the chicks, or a couple of chicks actually fell in the toilet, in the bowl there, and some of them drowned. I used to watch Baywatch with Pamela Anderson.
Oh yeah.
Goodness.
Back then, and I saw CPR for the first time in Baywatch, and I did CPR in a chick. In chicks, one survived, one died. One died, one survived.
You're resuscitated.
Oh my goodness.
I made for this.
That's great.
And when I performed CPR, or when I resuscitated a couple of patients there at Carltonville, I remember it was the second one after I had completed my ACLS course. First one didn't go successfully, the second one was. And I thought, but I was made for this. And I realized this when I was 7 years old. So that's why I'm here, because of a chick that I did CPR on.
Save lives. That's great.